Hey everyone, let's discuss APGAR scoring. When the baby is delivered in the delivery room, then you may be called to assess the patient if it is considered a high risk or other issue occurs during the birthing process. So the APGAR score was developed by Virginia APGAR back in the 1900s. It's named after her, and each letter of APGAR stands for a different type of criteria. So the first letter, A, is appearance, also known as color. B is pulse. C is grimace, also known as reflex irritability. D is activity, which is muscle movement and tone. And E is respiratory effort, which is the presence of a cry. So we can look at this criteria and decide if our infant needs intervention or is stable and can just be handed to mom for skin-to-skin contact. So this APGAR scoring is done at 1 minute and at 5 minutes. The scores are between 0 and 10. 0 is just horrid and 10 is fantastical. So it's really hard to get a score of 10 on the APGAR because of the trauma of the birthing process, even when it goes well. So each APGAR area is scored as a 0, 1, or 2 points. The higher the score, the better the condition of the infant. So if they have a 7 to 10 points, then we're going to hand the baby to mom and get that skin-to-skin contact bonding started. Provide routine care. Just observe. Have them call you if they observe any indications of respiratory distress. Otherwise, you should be able to go back to your other assignments. A score of 4 to 6, support the infant with oxygen, warmth, and general stimulation. We know that if the heart rate's higher than it typically should be, if it's above 160 up into 170 or more, that's a sign of hypoxemia, and the body is increasing the heart rate to try to compensate for that. So we want to give the baby some oxygen, maybe with an oxy hood is the most typical type of oxygen to apply. We can also use just a nasal CPAP with a minimal FiO2 and CPAP pressure that is effective to keep that PO2 between 60 and 80. And then we can put the baby under the warmer to combat hypothermia, which is really easy for the child to experience because of their ability to warm themselves is not quite developed as well as it should be. General stimulation, flicking of the foot or rubbing the back in order to stimulate ventilation. And then a point, 0 to 3 points tells us that we are likely going to have to perform CPR. It's usually a heart or lung issue, or sometimes both. So by looking at the APGAR scoring table, we look at appearance, which we talked about is color. If they are pink all over, we're going to give them 2 points. If they have a pink body but blue extremities, which we know is acrocyanosis, we're going to give them 1 point. And if they're blue all over, they don't get any points. That would be 0. The next portion is the pulse. And if it's greater than 100, then we're going to go ahead and give them 2 points. That's good. It's going to raise to between 130 and 160. If it's less than 100, they're only going to get 1 point on the APGAR score. And if they have no pulse, they're going to get no points. So if we look at grimace, which is their reflex irritability, if they get 2 points if they're coughing or sneezing. 1 point if they're just grimacing, and if they have no response and no reflex irritability, they get 0 points. Activity is next. If they're actively moving, they get 2 points. If there's some activity, but not as much as we would like to see of the extremities, they're only going to get 1 point. If they're limp and have no movement, they get 0 points. Respiratory effort is our last criteria. If they have a strong regular cry, we're going to give them 2 points. If they have a slow irregular cry, we're going to give them 1 point. And if they have no respiratory effort and they're apneic, then they get 0 points. So we know that our intervention and our care plan is going to be based on this APGAR score. So if they have 0 to 3 points, we're going to begin CPR. Resuscitation is going to be required. We're going to suction the mouth and nose first and establish the airway and clear the airway as quickly as possible. We're going to use a bag mask ventilation for support, and if that is difficult to bag the patient when you attempt to do so, then you know that there could be a compliance issue. We're going to do cardiac compressions if the heart rate is less than 60 per minute after 30 seconds of resuscitation. Our next point system is going to be 4 to 6 points, which we're going to stimulate and use oxygen. We may still have to resuscitate even at the 4 to 6 range. We're going to suction the mouth and the nose, assure the airway is clear, and support with bag mask ventilation if the heart rate's less than 100. 30 to 45% oxygen should be applied by oxyhood or a nasal cannula. Between the 7 and 10 point range, we just apply routine care, suction the mouth and nose, establish the airway, make sure that it's patent, and keep the baby warm. We can actually hand that to mom for the skin-to-skin contact at that point. So that's the APGAR scoring system. You will see questions about that on each exam. They will give you some details, and you should assess what the care plan should be based on those details and outcomes. So remember that to promote oxygenation with our infant, then we can use high flow, high humidity cannula. It's becoming more common to see in the NICU and in the newborn nursery than the oxygen hood. It causes a type of CPAP, and it's indicated if the baby is trying to develop some natural CPAP by grunting. So if you see the grunting sign, then you may consider actually applying some CPAP to provide that extra support with the high flow, high humidity cannula. Next is the oxy hood. It's the most common method used to deliver oxygen to a newborn, which involves placing a plastic or lucite hood over the infant's head. The oxygen should be analyzed in the hood by placing the analyzer probe nearest to the infant's mouth and nose. The therapeutic FiO2 range is 30 to 60%, but try to use the absolute minimum FiO2 that you can in order to oxygenate the baby efficiently. That way there's no toxicity and we don't have some of the side effects later on because of high FiO2 use. CPAP can be used when the infant is not adequately responding to the increased FiO2. So if there's some refractory seen during the oxyhood use or the high flow humidified cannula use. The CPAP is appropriate once the FiO2 reaches 50 to 60%, but the baby is still hypoxemic. Start super low at pressures of 2 to 5 centimeters of water. Don't exceed 8 centimeters of water. And the CPAP is often delivered by nasal mask, which kind of looks like a larger nasal cannula. So you can see photos of that on the study group at RRT and Neonatal Pediatric Specialist Respiratory Therapy Review Group. definitely consider joining us there. We go over a lot of things. We have daily questions posted. We have some live trivia games and live demonstrations and discussions about different aspects of respiratory therapy. So let's talk, just before we go, a little bit about ventilation of the infant. Most often, a time-cycled, pressure-limited ventilator is used. The time-cycled ventilator does not have a tidal volume setting, so tidal volume is controlled by the peak inspiratory pressure, so you have to monitor that to make sure that while you are staying within the 20 to 40 of PIP, the lower the better, that your tidal volumes are adequate and that the baby is receiving adequate minute ventilation to maintain the blood gas. Our I time needs to be set between 0.3 and 0.6 seconds with the infant. Our FiO2 should be set between 30 and 60% or to match the previous FiO2. The rate's going to be set between 20 and 40 breaths per minute, and the PEEP between 0 to 2 to start, or match the previous CPAP setting. The PEEP should not ever exceed 8 centimeters of water. That's very important. Stay below 8 and don't exceed that so that you don't negatively affect cardiac output and venous return and put the patient at risk for barrel trauma. So the mode that's most commonly used is SIMV mode if the patient is in a volume type vent setting. So your ventilator settings should be modified by looking at the ABG. The ABG should be managed just like adults except for the PO2. The PO2 should be maintained between 60 and 80 millimeters of mercury. And the key control of the PCO2 is peak inspiratory pressure as opposed to rate. The rate may be used once the peak inspiratory pressure can no longer be increased due to hemodynamic problems with the cardiac output, blood pressure, venous return, and we need to make small moves in the FiO2 of only 1 to 5% at a time. So you're going to see the options on the test when you're titrating FiO2 and other settings will be smaller changes with the infant age group than it is with the adult age group. So we may see some congenital heart defects. If you have continuous cyanosis, regardless of the FiO2 that you're applying, then you need to suspect there may be a congenital problem. And the best way to test for that is to use echocardiogram as the diagnostic test to begin with the care plan for any congenital heart defect. A lot of times we'll have to do surgery in order to correct the congenital heart problem, regardless of what it is. There's different surgical procedures. Sometimes they do correct themselves, but they have to be monitored by pediatric cardiology over a long period of time, usually, if they are of any significance. Even if they correct themselves, they're going to want to monitor that. So there are several different examples of congenital heart defects that we need to know the pathology for, as well as the signs and symptoms, what we might see on the x-ray. We know that if there is a tetralogy of Fallot, then we're going to see the boot sign, transposition of the great vessels. We're going to see the heart is going to be the shape of an egg. And so there's lots of different terminology that can give us keys to what the congenital heart defect is. And we'll do an entire recording of just that information and concentrate on that and expand on that coming up soon. Make sure you subscribe to the YouTube channel so you get updates when we add things, and come over to our study group at RRT and Neonatal Pediatric Specialist Respiratory Therapy Review, and we'll be glad to have you. Thank you.